Hi students, myself Babita Matthew. Every woman, when they become pregnant, they will be having a lot of dreams about their baby. They're expecting a baby to come out until 9 months. But sometimes it fails. They dies inside the uterus. So today we are going to discuss about the topic intrauterine fetal death. Let us see what is IUD. Intrauterine fetal death or IUD embraces all fetal deaths weighing 500 grams or more occurring both during pregnancy, that is antepartum death, or during labor, that is known as intrapartum death. This is the IUD. We can see the definition. WHO definition, that is fetal death measure means death prior to or complete expulsion or extraction from the mother of a fetus irrespective of duration of pregnancy and which is not an induced termination of pregnancy. So this is the fetal death. So it usually occurs before the expulsion of baby or before the extraction from the mother's uterus irrespective of duration of pregnancy. It is known as fetal death. We can see the causes of intrauterine death. Maternal complication first. Hypertensive disorders during pregnancy such as preeclampsia, eclampsia, chronic hypertension, chronic nephritis, etc. Diabetics in pregnancy such as maternal infections such as malaria, hepatitis, influenza, toxoplasma, syphilis, poliomyelitis, herpes simplex, mumps. These infections may cause sometimes intrauterine death. Then hyperpyrexia, that is temperature more than 39.4 degrees Celsius. Then antiphospholipid syndrome, that is APS. So in that time, presence of lupus anticoagulant, anticardiolipin antibodies that causes decidual vasculopathy with fibroid necrosis and placental vascular atherosis and intravillous thrombosis that causes intrauterine fetal death. Hereditary thrombophilias have been associated with abruption placenta, intrauterine growth restriction and IUD. Then abnormal labor, that is prolonged labor or obstructed labor. And rupture of uterus. We already studied these conditions previously. Post-term pregnancy, that is that is pregnancy exceeds more than 42 weeks of weeks. Then systemic lupus erythematosus. These are the maternal complications that causes intrauterine death. Next is the fetal complication, that is chromosomal abnormality, major structural abnormalities, infections, that is virus, bacteria, chorioamnionitis, then RH incompatibility, non-immune eye drops, growth restriction. These are fetal complications that may further lead to intrauterine death. Next is the placental. This antepartum hemorrhage, both the placenta previa and abruptio placentae, can cause fetal death by producing acute placental insufficiency. Then cord accident, that is cord prolapse, true node, cord around the neck, that also may cause the fetal death. Then twin transmission syndrome, when the twins one dead and one baby may affect the cause of other baby's death. Then placental insufficiency. These are the placental causes of intrauterine death. Next, iatrogenic. External cephalirection sometimes causes intrauterine death. Drugs such as quinine beyond therapeutic doses. When quinine drugs uses beyond the therapeutic doses, that may also further lead to intrauterine death. Next is idiopathy. Idiopathy causes remains unknown, even with the thorough clinical examination and investigation to find out. Next we can see the morbid pathology. So the dead fetus undergo an aseptic degenerative process called maceration. And the epidermis is the first structure to undergo the process. So epidermis layer first goes for the maceration, whereby blistering and peeling of the skin occur. It appears between 12 to 24 hours after death. The fetus becomes swollen and looks dusky red. You can see from the picture, and gradually aseptic autolysis of the ligamentous structure and liquefaction, that is like a liquid formation of the brain matter and other viscera take place. The changes vary in degree and are responsible for the characteristic radiological signs. This is the morbid pathology. We can see the symptoms: absence of fetal movements which are previously noted by the patient. So usually mother feels the fetal movement after 16th week. So at 16th to 20th week, in between that time, they feel the fetal movement. So they already felt the fetal movement, but they cannot feel the fetal movements. That is the absence of fetal movement. Next, signs: retrogression of the positive breast changes that occur during the pregnancy. So when the pregnancy, when the woman become pregnant, they will be having the positive breast changes. So that changes will be returned back to normal stage. That is a retrogression, return to the previous state, is evident after variable period following death of the fetus. Next, per abdomen, what all the symptoms can be seen? That is gradual retrogression of the fundal height. So the fundal height will not be raised up and it becomes smaller than the period of amenorrhea. The uterus usually raises up each weeks of gestation, but it will be gradually reduced after the death of the fetus. Then uterine tone is diminished and the uterus feels flaccid. Braxton's his contraction is not easily felt. Braxton's his contraction is the false contraction. It will not be felt. And fetal movements are not felt during the palpation. We cannot feel the fetal movements, and fetal heart sound is absent. Eggshell cracking feel of the fetal head is a late feature. It's like an eggshell crack feel can be seen. That is because of the fracture of the, or the compression, or the fracture of the fetal skull will occur later on. So that is the eggshell cracking feel can be felt. Then investigation. How can we find out that the baby is dead in the uterus? That is first we have to do for the ultrasonography. The lack of fetal motion, including the cardiac motion, cannot be seen during a 10 minutes period of careful observation with a real-time sonar is a strong percentage evidence of fetal death. Then gradually oligohydramnios and collapsed cranial bones. That's why the eggshell crack feel there. That is, collapsed cranial bones are evident. Next, the investigation. Now already we said USD. So 100% is we can find out by the USD. Associated with chest can be noted, that is oligo and hydrops, and straight X-ray of abdomen if we seen. If we taken the absolute, that is robot sign, the appearance of gas shadow can be seen within 12 hours. That is known as robot sign. Next is Spalding sign. Spalding sign is the collapsed skull bone can be usually appears within 7 days after the death of the baby. Then ball sign. Ball sign is a hyperflexion of the spine because of their capacity is lost. That's why ball sign, there is hyperflexion of the spine can be noted. Then helix sign. Helix sign is the gas in the umbilical arteries can be seen. Then crowding of the ribs. Ribs become crowd. So because its elasticity lost, that's why it become crowding, or the ribs can be noted. Next, in the blood investigation to estimate the blood fibrinogen, it will be elevated. So that's why fibrinogen level should be checked, and partial thermoplastic time periodically when fetus is retained in for more than 2 weeks. Then evaluation for the stillbirth. What all the evaluation should be done for the stillbirth? That is hematological examination, ABU and RH grouping, and Kleho-Betke test. This should be done to check out for the preterm or postpartum. Then VDRL and postprandial blood sugar, HbA1c, urea creatinine estimations, thyroid profile, TORCH screening, lupus anticoagulants, anticardiolipin antibodies, and thrombophilia studies. Okay, these are the evaluation of a stillbirth is confirmed. Then urine examination for casts and pus cells, and thorough examination of the infant and plasma should be done. The infant for any malformation, umbilical cord for enlargement and number of vessels, and placenta for meconium staining, malformation, and the respective weights are to be noted. According to the weeks, how much weight is there for the baby should be noted. Then autopsy is very important. Autopsy and chromosomes studies are done for the fetus with the anomalies and dysmorphic features. It is also done if there is history of recurrent stillbirth, or if either parent is a carrier of balanced translation. Then fetal skin, this is done by fetal skin. Blood are usually taken for cytogenetic studies. Tissue must taken, some viable cells also taken. These are the autopsy and chromosome studies. Then management depends upon the condition. We are doing the management. It's a single or multiple gestation and gestation age at death and parents' wish, that is according to their varied response, and expected approach, that is 80% goes in labor within 2 to 3 weeks. And emotional burden, risk of chorioamnionitis and DIC, and active approach. This is all done according to this condition, and according to these factors we will do the management. So first is induction of labor. It is you already studied in previous class, that is about what are the methods used for the induction of labor. So fetal death, that is 28 less than 28 weeks, we can start the mifepristone 200 mg followed by misoprostol 400 mg, 4 to 6 hourly, most effective with the shortest interval. Then fetal death more than 28 weeks and cervical opening, that is mechanical and chemical, followed by oxytocin. So we can use this same drug method, and then we can start the oxygen if it is the baby is more than 28 weeks. Then WHO recommendation of misoprostol in IUD cases are at term, if the baby is dead at term, 25 microgram, 6th hourly 2 doses. If no response, increase to 50 microgram with the 6th hourly, do not exceed 4 doses. Do not use oxytocin in 8 hours of using misoprostol, and contraindicated in if the woman have the previous cesarean section. We will not do the induction of labor. Then RCOG and NICE regimen are if less than 26 weeks, 100 microgram mg 6th hourly, maximum 4 doses. More than 27 weeks, 25 to 50 mg 4th hourly, that is maximum 6 doses. And use of prostaglandins is associated with the increased risk of uterine rupture in case of previous scar. Then membrane should not be ruptured as long as possible, and pain management should be offered, and keep watch on CBC, coagulation profile, signs of any infection. And active management of third stage of labor should be done, and keep blood and blood products ready. This is a scheme of management. Till now we seen this, and it's a regimen with a non-interference for 7 to interference for 7 to 10 days, and refractory cases or cases where early delivery is indicated, and psychological we have checked for the psychological status of the mother, the infection, falling fibrinogen level, retained more than 2 weeks. Then we have to do the hospitalization and medical indication. If the cervix is favorable, oxytocin infusion IV, and fails, repeat oxytocin with vaginal prostaglandin and supplementation. And vagina is cervix is favorable, not favorable, prostaglandin gel intracervical or prostaglandin tab vagina oral may have to be repeated after 6 to 8 hours, and fails supplementation with the oxytocin infusion. Then we can do the delivery and evaluation force of stillbirth, and bereavement management should be done. So what are the complication of IUD? It may sometimes go for infection and postpartum hemorrhage, retained placenta, abruption, demise, shock, renal failure, sepsis, and maternal death may be occur. After the delivery, that is a post-delivery, the mother's mental status is very horrible, so we have to give proper emotional support and counseling, as they are at increased risk of postpartum depression, because from the time when they know that they become pregnant, they make a lot of dreams about their baby. So suddenly they lost, they will become very depressed, so they may go for the postpartum depression. So keep in non-maternity ward, and because when they see the other patient's baby, they become very sad. So that's why we have to keep them separate. And suppression of lactation, because breast milk usually produces, that's why suppression of lactation with a tight breast support and dopamine agonist and estrogen can be provided. And counsel for the further pregnancy, early antenatal visit, and preconceptional testing should be advised, and assurance in cases of non-recurring recurring causes, and contraceptive counsel should be advised. Then management of the future pregnancy. If one baby lost, they have to become pregnant next time. So what all the management should be done for the future pregnancy? Preconception or initial pregnant parental visit, detailed medical and obstetrical history should be taken, evaluation and workup of previous stillbirth, determination of recurrence risk, and smoking cessation. Weight loss if the woman is obese, preconception only. Then genetic counseling if family genetic condition exists, and medical problems like diabetes should be managed prior they become pregnant. And thrombophilia workup, that is angiolipid antibodies should be checked only if specifically indicated. Risk of recurrence is 7 to 10% in 1000 birth. So it should be, risk should be maintained. Support and reassurance should be done. Next is what are the things done in the first trimester? Dating, that is the early sonography should be done. And first trimester scan, pregnancy associated plasma, protein A, B, HCG, and nuptial transcendency should be checked, and folic acid should be provided mandatory. Then fetal, in second trimester, fetal ultrasonographic anatomic survey at 18 to 20 weeks should be done. And maternal serum screening, that is quadruple marker should be done, and blood investigation should be done in the second trimester. In third trimester, sonographic screening for the fetal growth restriction after 28 weeks of gestation. Then admission of at a critical period in high risk cases, and kick counts, that means tell them to count the fetal movement count starting at 18th week of gestation onwards. Then antepartum fetal surveillance starting at 32 weeks or 1 to 2 weeks earlier than the prior stillbirth. Priorly, if they which week they lost their baby, so before that time, it's well, we have to start the antepartum fetal surveillance starting at 32 weeks or 1 to 2 weeks earlier than prior stillbirth. And weekly fetal heart rate and BPP, biophysical profile, and Doppler should be done, and support and reassurance should be given. Next is the strategies for prevention. No show of fire method to prevent losing weight, lifestyle modification. Women should try to optimize their health prior to become pregnancy, and encourage folic acid before they get pregnant, and good preconception and prenatal care should be given. Women with the diabetes mellitus, diet control before they become pregnant and during the pregnancy also, and educate the woman not to delay pregnancy. So when you lose a person you love so much, surviving the loss is very difficult. So when a mother lost their child, they become very depressed. So make them live by giving proper antenatal care and proper advice. We can make them support during their struggle period. So this is all about the intrauterine death. I think all of you clearly understood. So that's all. Thank you.